We're going to go ahead and get started. So good afternoon, everyone, and welcome. Thank you for joining us today for the National Hispanic Medical Association's Hispanic Heritage Month Roundtable webinar on increasing physicians and medical education, two separate topics. My name is Dr. Michael Galvez. I am the Director of Pediatric Hand Surgery at Valley Children's in the Central Valley, and I'm the co-founder with Dr. Cesar Padilla of National Latino Physician Day. And so I'll be serving as a moderator for today's event. The National Hispanic Medical Association, NHMA, is a nonprofit association representing the interests of over 50,000 licensed Hispanic physicians across the United States. NHMA's mission is to empower Hispanic physicians to lead efforts to improve the health of Hispanic and other underserved populations. NHMA hopes to engage medical students in exploring the challenges and opportunities that Latino physicians face, highlighting the significance of medical Spanish in both academic and clinical settings, and discuss strategies for improving representation and advocacy within the medical field. We also wanted to take the opportunity here, and I'm grateful for NHMA for this, to highlight National Latino Physician Day, which is on October 1st, coming up next week. The mission of National Latino Physician Day, I'm going to read it right here. So to address the Latino physician shortage crisis, the mission of National Latino Physician Day is to improve the quality of care for the United States Latino patient population by increasing the number of Latino and Latina physicians who provide culturally and linguistically concordant care. And so really grateful to have this platform. I'm really excited for everyone to be engaged on social media and live events across the country. In California, there's particularly several, and please reach out if you have any questions. Check out the website too, has all the information. You don't need a t-shirt. You can see me and Dr. Mora are wearing our National Latino Physician Day t-shirts, but you don't need a t-shirt, right? This is a movement, and so we're grateful for everyone and anyone to be involved to create this awareness. And so we're honored to have a distinguished panel of experts who will provide valuable insights and share their experiences. And so let me introduce our panelists today. So as I mentioned, Dr. Juanita Mora, she's the CEO and physician at the Chicago Allergy Center and National Medical Spokesperson at the American Lung Association. Thank you so much for being here, Dr. Mora.
Thank you for having me.
Fantastic. Dr. Geraldine Luna, who is the medical director for the Inclusion, Diversity, Equity, and Access Bureau at the Chicago Department of Public Health. Thank you for being here, Dr. Luna.
Thank you for having me. It's a pleasure.
Thank you. And then Dr. José Cucalón Calderón is an associate professor of pediatrics at the University of Nevada, Reno School of Medicine, and chair of the NHMA Nevada chapter. Thank you for being here.
Thank you for having me, and happy to talk to everybody today.
Fantastic. So during this roundtable, we hope to highlight the need to improve representation in health-related fields, advocacy, and research, as well as to provide insights from Latino physicians with varying backgrounds in medicine. For everyone who's watching live, we ask if you have any questions, please drop them in the Q&A box, and we will incorporate them into the discussion at the end. And so thank you for joining us today, and we will engage in this lively discussion. So we'll start off with our questions. Our opening question is, so to start out, and what we'll do is we'll start in exactly that order. And for some of these questions, I'll include myself, but to start off, and we'll do that order of Dr. Mora, Dr. Luna, and then Dr. Calderón. So the opening question is how can each of you briefly share your personal journey into medicine and how your Latino heritage has influenced your career? And so I'll start off. I always talk about how I was privileged. I was privileged because my parents are from Lima, Peru, and my abuelito was a pediatric surgeon in Lima. And they came to the United States during Sendero Luminoso and started a new life, essentially. My grandfather was over 50 at the time, and there was no way he was going to go through medical training or try to practice medicine here in the United States. And so he would take care of us as a kid, even though we didn't have health insurance. And so I was always inspired and knew that I could become a physician because my grandfather was a physician. And that's the privilege that I talk about. And my journey into medicine was, I started off with community college. I did terrible in high school, but I got my act together. and then subsequently went to UC Berkeley, and then did research at UCSF, and then spent 11 years at Stanford training in for medical school and then for residency. And then I decided that I wanted to help kids with pediatric hand problems, because I went on a mission trip to Bolivia and La Paz, and I saw so many kids with burn injuries and congenital hand differences. And I'm grateful to being able to do that work here in the Central Valley, where we have so many kids that are in need of this access, and a high percentage of Latino patients. And I like to talk about this in my talks, but I start off my talk saying I come from the future, because over 66% of my patients are Latino. And that is, we are currently experiencing that increase in Latino patient population. Go ahead, Dr. Mora.
Well, beautiful story, Michael. Glad to hear it. So I think many will resonate with my story. I'm a first-generation Mexican-American. My dad, a butcher, trabajaba carnicero, empacadora. My mom, a stay-at-home mom. And I can pinpoint the exact moment when I decided to be a doctor. And it was something that I think people will basically really relate to. Is my mom fell ill when she had my youngest sister, and developed eclampsia, killed her kidneys, and we had to wait to see a nephrologist. And of course, as her oldest child, I had to be her little translator, as many of you had to be for your parents. And I remember having to sit there hours waiting for a real translator, obviously, to be there to explain to my mom that she had kidney failure. And I remember being this impatient 7-year-old little girl and telling my mommy, why does it take so long for us to see a doctor? And then she turned around to me and said, because there's simply not enough doctors who speak Spanish. And of course, this feisty 7-year-old that still lives in me turns around to my mommy and says, well, I know what I want to be when I grow up. I want to be a doctor so I can help the community and I can talk to them in Spanish. Little did I know that it was going to be that fire that really led me towards my career. I'm born and raised here in Chicago, went to college, University of Chicago, then UIC College of Medicine. I did med-peds for residency and then allergy and immunology for fellowship. And that led me towards truly working with the Latino community, not only on a local level, but on a national level, and truly loving what I do and knowing that this service is needed for our community and touching every patient's lives.
Fantastic. Thank you. Dr. Luna, could you share your personal story as well?
Of course, and thank you for having me. In my case, I'm from Puerto Rico, so I was born in New York. At 5 years old, my family migrated to Puerto Rico. We had to take care of la abuelita, el abuelito. So it's culturally, like in the island, you see that a lot, that the multi-generational family. So I was the classic multi-generational family. We were all fitting in the same house. Mi abuelita, mi abuelito, my family of 6. And then my other cousins were living around also with my tío and another tía with 3 more kids. So imagine the transit of individuals in there. I knew I wanted to become a doctor when my abuelita, we didn't have insurance. Of course, Reforma de Salud came later on to a commonwealth. So the island really has like significant cut downs in the economy. They're always struggling for resources. You don't see that much, because it's not part of the problems of the United States per se, but this is our reality here in the island. So when my abuelita started getting sick with emphysema, because one thing they do, my abuelita was like a stubborn individual, and I think that's where we get this resiliency, we get this fierceness and fighting for the things that we believe in, and is that she would have emphysema because she was a chronic smoker, and even with the oxygen tank, she had the cigarette on the side. I don't know if you can relate or if you see that in our Latino family, but you don't change who they are. It's hasta la muerte. And we will go back and forth. Our primary care provider was the emergency room. And we saw a lot of that. And I knew then and there, like, it has to be something is wrong about this. I had to wait hours and hours to see a physician just to treat things that we could have prevented, especially when it came to the care of individuals with chronic diseases. So that was my wake-up call a reality. And then when I grew up later on, I was the first one to go to college, to medical school. And then I trained in Puerto Rico. I met my husband there. I had my daughter as a medical student and raising up a child as resident. So there were tough times, but at the same time, beautiful learning lessons. And then I came to the United States of America, to Chicago. I've been living here 15 years, and here I completed my subspecialty in geriatrics, as my husband did. So both of us came together to complete that part. And it was here in the United States that I became aware of disparities, like certain races with differences, like living longer. We have streets in Chicago that you cross the street and individuals live 30 years more. Life expectancy is longer. So that reality came to be. And then I noticed when I came here to Chicago that our Latino community would look up to me, like, and I understood that there are differences in the way that we impart medicine, and that not everyone has the ability to get a doctor that speak their own language and look like them, and how important it was for them and impacts of healthcare, and how those outcomes were negative when these situations were not happening. So that I became faculty here in geriatrics at UIC, that I did my geriatric training there. And then is when I decided to do a training in public health. Once I started to do that, the pandemic hit in 2020, and I'm the first Latino doctor here in the Department of Public Health. There's no one else, even though we're not minority here in Chicago. 30% of the population in Chicago is Latino and growing the fastest. And then we have Black 30% and white pretty much around 30%. So we're not minorities here, but we're definitely minoritized, and we are segregated and we're marginalized living in our communities. And this is where public health became so important to me. So if you haven't been, like chosen your career path yet, please consider public health, because there's an incredible need to sit at the table and make those differences. So that's my story in a nutshell.
Thank you so much for sharing. That's awesome. Yeah, it's so many great points, and exactly like we're going to be going through some of these aspects, but just how there's very few of us, but we are, we're quickly growing, and in Chicago, like you said, it's 30% of the population, and that's a very large population that lives in Chicago. So thank you for that. Dr. Calderón.
Hola a todos. Hope everybody's having a good morning, a good afternoon. So I'm originally from Guayaquil, Ecuador. I'm an immigrant. I'm an immigrant physician, a native Spanish speaker who moved to the United States to actually do my pediatric residency training with the privilege of being able to make my first trip to the United States when I was 6 years old to be able to have an evaluation for asthma, because I was having asthma that was problematic. Had some allergies and stuff like that, but the bigger thing that pretty much everybody was telling my dad all the time was, yeah, you need to quit smoking. That's why your kid is not doing very well. And which ended up starting this pathway of on trying to understand things that were going on with me. Also the fact that I was lucky enough to get exposed to my grandfather, who is a fellowship trained urologist here in the United States, who moved back to Ecuador and ran the largest cancer institute in my country for years and years and years, leading transformation of a healthcare system, population change, as research, as well as disrupting and advocating for the families that he would serve, without charging them a lot of the time. With all of this, plus some opportunities that my medical school offered, I came to do a rotation in the U.S. in the Jackson Memorial Hospital in Miami. And during the first day of pediatric hematology oncology rounds at that institution, where we sat down with the attending, the fellow, the 2 residents, the intern, the 2 students, me, the observer, the social worker, the pharmacist, the radiologist, And within 10 minutes of the first patient, they had already discussed about more things to support these kids and these families' needs than I had done in my whole 6 months of pediatrics in Ecuador, which is all of this together is kind of why I ended up deciding to come to the US. I trained in Mobile, Alabama. I did my residency in the University of South Alabama. And then I stayed in rural medicine for 3.5 more years in Alabama in a 10,000 people town. Then moving to Reno, Nevada, which had a very different demographic than Alabama, Florida ever did, which had been the two places where I had had the most of my exposure in the United States. But the need was the same. It was just overrepresented in different ethnic groups other than white, with worse health outcomes, issues with access, issues with language, issues with trust. When I moved to Nevada, I was personally surprised to see that 30% of the population was Latino, and that there was a lot of people waiting for me to start not only finding ways of collaborating, but also giving feedback on the services and on creating new things. And there was funding waiting, opportunities waiting, which is kind of what led me to be able to grow my role at the American Academy of Pediatrics for the state and then the national level, as well as being able to launch the chapter here in the state of Nevada for NHMA. I am proud to say that I am an NHMA leadership fellow with a lot of the skills actually being developed and polished through not only the practice here, but also through my exposure and the partnership and the support of NHMA. And I am here today in my hope that I can also be offer some of those things for our students and younger and older in the career physicians, as we need to support each other, because seeing it and being it for people to see it and be visible is going to encourage people to be able to take part into this work and then grow our bases, which definitely we need to be able to better meet community needs. And the United States is Latino now, so that's going to continue happening more and more.
Awesome. Thank you so much for that. As you can see through several of our stories, everything is intertwined in our experiences. And even as we go through training, we see things mirrored. For me, I was from California. I went to Seattle, then went to Dallas, and then back to California for my training. But you see everything mirrored. You see the lack of diversity in some of these in some of these settings in the physician workforce. And so that goes into the next question. So diversity in the medical workforce is crucial for improving patient care and outcomes. And currently Latinos, as we know, comprise only 6.9% of the physician workforce in the United States. Can you discuss some of the barriers that Latino physicians face in entering and advancing within the field of medicine? And so I'll start this part off. And there's so many barriers. And we're gonna all probably chime in on these different things. But I like talking about my personal experience, right? I had a 3.9 GPA in community college because what you would study, you would be tested on. And then I went to Berkeley. It was the hardest thing I've done in my life. You would study and they would make stuff up. No matter how much you studied, you couldn't do well on the test. I always talk about this physics problem. The monkey shoots through the air and lands somewhere in the physics problem. And then on the test day, the monkey hits a fan and starts spinning and then, lands somewhere else. And so they give you something completely different. And it really doesn't correlate to getting and becoming a physician in the workforce, And so the first barrier I would say is I do think there are colleges where these barriers exist, where you end up finishing college and you end up having, for me at Berkeley, I had a 3.1 at the end. I had 1 A in one class, but there are so many students that come out finishing college with a 2.8 GPA, and there's Latino students, and they're in purgatory. Because they have to do they have to take post-bac years, they're digging themselves out of this hole. And so I think that is a big barrier that we don't necessarily talk about a lot, but I think the undergraduate areas are a barrier. And then the other one is the MCAT, which we know is specifically biased against, we know it's biased against Latinos and people that speak an additional language like Spanish. And so those are some of the barriers that I think of immediately when I think about Latinos getting into becoming a physician. And then we can talk about, there's a lot to talk about. So as you know, I can keep going. So I will let Dr. Mora go next to answer this question. Can you discuss some of the barriers that Latinos face and then advancing within the field of medicine?
Of course, one big one is financial barrier. So a lot of Latinos get discouraged because they feel like, oh my gosh, I'm going to enter into so much debt. I don't want to do that. And, you know, it's such a long career. Two is, I always say too, that a lot of people, especially in the Latino community and African American community, they allow their dreams to be shattered by people who shouldn't be shattering them, because there's not enough role models within the school systems from grade school and high school and college so that you can mirror the actual behavior. So I think mentorship is going to be so important in advancing, and the lack of mentorship is a huge problem, and lack of belief in a community, because they're like, well, you know, my parents don't really earn that much money. Maybe I shouldn't think of becoming a doctor. And then the third one that I always see tons of is, you know, maybe I'm not smart enough. That's self-doubt. And we're here, all of us are here to tell you that if we did it, you can do it as well.
Awesome. Thank you for that. I completely agree. The socioeconomic aspect is huge. And that actually is what results. The MCAT is an example. Like you have a student who is in a suburb, protected, has a place to study, right? And has time and doesn't have to work. And then you have a Latino student who has to work for the socioeconomic reasons and makes those decisions that I'm going to study, I'm going to be going to school, and I'm going to take the MCAT at the same time. How many times have we heard that story? And so those strategies is where a mentorship and guidance allows students to navigate this pathway. And Dr. Luna, do you have any additional barriers to add?
Yes, I can tell you from academic institution, as I'm working as a faculty for geriatrics, I think one of the most important barriers, aside from the lack of representation, we don't even mirror the community that we serve. You can tell them that Latinos are like, you can count them on a finger if you go to academia or any other of the settings that we provide our services to. So I think that not having, I have to echo Juanita, but also the sponsors, like creating that network to advance your career is so important. And having individuals invested in helping a Latino is not that easy when you go to academic setting. Another thing is tokenization. I feel that most of our grants, for example, UIC is, and not to put them on the spot, it's not, you know, to villainize any particular institution, but I work there, so I can tell you a little bit about that. It's a Hispanic serving institution. So that means 35% of the individuals accepted to any of their curriculums or any of their programs have to be Latino. But then we see that licky pipe, like finding out that only from that 35% of the population that goes to institution, only 36 graduate with a degree. That tells you there is an important thing, there's something lacking. I mean, we're talking about significant, terrible interruptions, and of those, who of those achieve a medical career? So that's one of the things that we're working in policy. We're doing it with NHMA to try to change the face of how it looks. If you're going to get a commitment which is tied by money, then we might as well have accountability and responsibility of those organizations having mentorship programs or programs in general that help Latino achieve their dream aspirations. And we have that representation, but not just right there. Here in the Department of Public Health, we're talking about a completely different landscape. I'm the only Latino sitting here in those seats. And I can't tell you that I'm completely making, sitting at the table when we're making such an important decisions when we represent 30% of the population here in Chicago. So we have to, I mean, this group right here, the one sitting in front of me like that, I can see, and you guys are the future of how we look and how strong we can advocate to make these changes. Organizations like the National Hispanic Medical Association is heavily focused on that advocacy with the people that really matters and it makes a difference. So we need to sit down, strategize. We need to come together. That's one of the barriers we represent. We don't have a network that really works in an advantage and to portray and not to portray, but to push our Latino agenda further. And that is some of the important barriers that I feel that we have when we come to this field here in the United States of America.
Thank you for that. No, I definitely agree that there's definitely work to do to improve our networking and our pathway, even within, we're just at the Latino Medical Student Association National Conference last week. Fantastic. There was over 1,000, like 500 students, faculty. And as we, bridge students to NHMA and beyond and networking and bringing things together, it's important, right? And we were just talking about earlier off the Zoom call, but even within our state, there may be some Latino physicians that aren't aware of our organizations. And so we need, if we're just 6.9%, we need everyone on board. We need all hands on deck to create and improve this network so we have more mentors, so we have more pathways. And I do think with this movement, the hope is with National Latino Physician Day, we will create this awareness and bridge these things together. Dr. Calderón, anything else to add? I know we can talk about barriers for a long, long time.
So 2 things only. I would echo mentorship. How are you going to encourage people to do something or follow something when you don't see yourself in that position or somebody that has something in common with you? That was a big issue for me especially during residency and my first bout of professional life, because I was the only Latino and I was the only Latino physician in pretty much all of Central Nevada, Alabama. And then when I came to Nevada, I was the only native Spanish-speaking physician in all of Northern Nevada, pediatrician in all of Northern Nevada. Mm-hmm. So the mentorship opportunities came, and I was able to find really good people who supported, who always were supportive of my career, and then you also consider that part of the reason some of the things we have been able to do here in Nevada has happened is because people were ready to have a Latino voice, who had experience working with underserved communities to actually have a seat at the table. So it was kind of preset. So if you are making choices or providing support to Latino communities, it's important for us to have a seat at the table and talk about not only our experiences, but also what we are seeing in clinic, what we are practicing, and research that, and then let that guide policy let that guide policy and advocacy as we move forward. But we need to have the Latino leaders first, the people who are doing the work. On the other side of things, our institution is about to become a Hispanic serving institution, and I reflect back on that because I had a student with our classes increasingly becoming more Latino, here reflecting a little bit more of our population in Northern Nevada, who told me that I was the first physician on her 4th year that was Latino in her whole medical school. So a 4th year person who is about to graduate, who is Latina herself, who never had the opportunity to work with somebody that she would have something that she could call as something in common or a similar cultural background. This person also identified as a native Spanish speaker. So it's important for that to happen earlier, to be able to create those opportunities for mentorship and support so you can better understand not only what your students want, what they need, as well as being able to get them engaged in working in their community that they come from, and then have the leadership roles and everything else. So it's a continuum that works, I feel, both ways. We are becoming an HSI, and we don't have the faculty to actually support being HSI. So that's also can be a big barrier, since we were talking about barriers earlier.
Yeah, no, those are great points. Yeah, the HSI, it took me a while to kind of learn a little bit about what that meant. And it's related really to students, right? Hispanic Serving Institution for Students. But what about Hispanic? So you also want to have the employees, right, of the institution be Hispanic, right? So it should also be a Hispanic employed institution. And then finally, the public, it should also be Hispanic serving to the public, right, for that institution. So there really is like, who created this HSI? Yeah, that's great that it's serving students, but we need faculty, we need it to serve the public. And so the continuum is incredibly important. So we have 4 more topics to cover. It's a lot, but we will proceed. The next one is medical Spanish. So one of the key components of today's discussion is the value of medical Spanish, being bilingual. How does proficiency in medical Spanish enhance patient care and academic outcomes? And then can we share specific examples where this could make a difference, and then whether in practice or in research? And so for me, myself, mi mamá me forzó a hablar español. You know, I was born here in the United States, but I'm really glad she forced me, because my patient population, like I mentioned, is 66% Latino, with, you know, about half of those speaking Spanish. And so it makes a huge difference, and it results in immediate outcomes in surgery, for example, because I can tell a patient in Spanish and instill some fear that after their surgery, they need to protect the surgery, like tienes que mantener el yeso limpio, seco, elevado, tiene que mantener el niño adentro, requiere supervisión. Just like that, I just communicated a lot, and it goes in, and it's applied by that family. And so really, I see it clinically, and it results in better outcomes for my families. So that is just one small example. So can you provide us an example, Dr. Mora?
Sure. I honestly think that knowing medical Spanish equals cultural competency, which increases and translates to better health outcomes. And I can tell you, as an allergist and immunologist in Chicago, so when a family comes in and they're like, me puse vaporú en el pecho porque el niño ha tenido resollido, like an asthma exacerbation, you can explain to them, they can continue their Vaporub, le pueden dar la canelita, but they have to start inhalers. It's asthma, so you explain it. And I think, one, it draws you in because they trust you because you speak their language. And 2, you can also communicate it effectively. And 3, you become a trusted voice in their household, which I think is so important in making better outcomes and making better decisions as well, too. And teaching them that we can do a crossover of culture and Western medicine as well, too, within a clinic setting.
Fantastic.
Yeah, I would have to add to that to me, it was easy, like medical Spanish, because I train in Puerto Rico, so Spanish is what we do there. But coming here, I understood. I had individuals, and because I agree, I have to echo what Michael said. I have to echo what Juanita said. It's competencies. You're talking about cultural and linguistic concordancy with the population you're serving. But I would have to give you a testimony of one of my patients that will allow me to share the story very overall, not any specifics. But I had an individual there, one of my viejitas that as a geriatrician I see, and she has been living in the United States for 40 years. And it was recently that she came to me because not only once, but multiple occasions that she went to seek medical care. Nobody understood her. She was dismissed. She was mislabeled. And the most important thing is that she never developed the trust to see her doctor. And when she came to me, it has been like 45 years and only scattered medical care here and there. And she missed out on so many opportunities, even for her to have children when she was back there reproductive. It was a lot of things that were taken care of. And one of the things I remember being the most rewarding one of this situation, and just to make it short, long story short, but she was crying, doctora, si viera, nunca me habían podido hablar el español, nunca me habían podido hablar en un idioma que entendieran, nunca pude decirle la realidad de lo que ocurrió. And she suffered significantly when she was young, within domestic violence and all the other characteristic things of individuals that are unable to tell their story in a timely fashion, to seek for medical care, to seek for care over and connect to resources. So this is where she came to me, and she was crying. and hugging me, please don't go, please don't go. Please stay around because I really need somebody that I can trust to tell my story, to comfort, to convey the important things of medical care. So when you go out there, medical Spanish is everything. It represents you. And I would highly, highly encourage that if your Spanish is not completely conversational, make it conversation. It's going to only happen with practice. And your patients are going to benefit from this individual, these conversations the most. So you're really serving your community by continuing to provide competent Spanish and cultural and linguistic appropriateness to those individuals that you care for. So that is a piece of a little bit, just to make it round, you can get a little bit of scope of what's happening out, what's happening in the communities that we're serving here in the United States.
Fantastic. Yeah, and that bilingual aspect is so important. And in Puerto Rico, there's 4 medical schools, and they are all bilingual, bicultural. And so we really lack that in the United States. And it's just a very interesting concept and something we've talked about before, that there currently doesn't exist a Latino medical school in the United States. There is no bilingual, bicultural medical school in the United States, in the mainland. And just something, that hopefully with these ongoing efforts that we can see some of these changes happen within our lifetime. So Dr. Calderón, about Spanish.
So you don't have a bilingual, bicultural medical school, but you still can find workarounds. So we are now about to enter our 4th year of having a medical Spanish, a Spanish for medical encounters elective here at UNR Med, that I designed the clinical portion of it, and then a couple of people who are no longer here designed the curricular part, the structure part. But I have stayed as rotation director for it, and because of the value that it brings to our community and the experience that our students get. So this is meant for people who already are at a certain level of Spanish to actually practice being able to deliver and obtain medical information using Spanish, lay terms, being able to, or medical terms, and then engage in communication, and then to reflect back on what those patients' experiences and concerns and capacities and possibilities and resources are. Because if the really important thing about medical Spanish is absolutely we're going to be able to give better instructions that are going to be better understood by the patients, but it also allows us to practice cultural humility when we are delivering care. So how are we going to reflect back and collaborate with families if we don't know why they do things the way that they do it? And they are the authority on their experience and their day-to-day life. It's great placing a referral, but or putting lab work for people and then agreeing to do it. But if they have 3 jobs 3 jobs to go to every single day to keep their 5 kids fed, then how are you going to be able to help them navigate that if you don't know about it? So the reflecting back on this definitely helps. The other thing is that my interest in this, it was during my years in Alabama, because I was the smack dab Latino in Alabama, in Southern Alabama, working with every single population that you can imagine, but Latinos down there. And I was the only physician in my whole class that was Latino himself. So I wasn't getting the patient, even though I was speaking English and I was communicating in English, I wasn't understanding what was going on with follow-up and the delivery of care about things not happening. I'm the doctor, I'm giving you the orders, I'm telling you this, I'm doing that. Why are you not following through? Oh my God, these people are non-compliant. Oh my God, they don't want to make a change. I have to think about, so, which was really easy. And then one time I just had I think it was a bright idea to start asking them why. and I did it more as a survival skill and trying to work what was best for my patients, and then reflecting back on what their answers were and provide support in that way. I had no idea that I was practicing cultural humility at the time. This also allowed me to be able to reflect back on trauma experiences and adjust the delivery of care based on trauma, because There is trauma-informed care, and it's currently recognized as best practices. But if you are unable to assess for that and understand where people come from and what their experience is, because you have a language barrier, then you're not going to get anywhere with that. Okay, so that would be my big input as to why we keep the rotation going, is because not only do we want our students and to practice in being able to obtain and deliver medical information, but also on be able to create reflective care, validating the patient's experiences and their ability to be able to troubleshoot and communicate that with us so we can partner up.
Thank you so much for going into practicing cultural humility, Dr. Calderón. Would anyone else like to chime in as far as that important aspect? And I do think it really, exactly as you said, like the electronic medical record system was also not made for many cultures. Just because you put an order in doesn't mean it's going to happen, right? It requires that additional care and follow-up to provide comprehensive care, and checking those boxes off. And so, yeah, I just wanted to see if we're going to move on to the next question, but I think we covered, just thank you so much for discussing cultural humility with us, Dr. Calderón. Dr. Mora or Dr. Luna, any other additions?
No, I think practicing cultural humility is, I think, part of what makes us Latino, I think, in treating these families. And really, you not only bond with them as their doctor, but you sort of you get treated as family. I'm sure we all have stories of patients coming in con tamales, con pan. I work every Saturday, so people always bring stuff in, and I love it. It's that trust factor. I mean, on a Saturday, I will see families from la abuelita to the youngest kid. Everyone will get a flu shot this season. And I give 50 flu shots on a Saturday morning. And it's amazing. I love it.
Fantastic. So we'll go ahead. Oh, go ahead, Dr. Luna.
Oh, sorry. And I would have to add that coming from a Latino background makes you conscious. I mean, we are aware that we have multicultural, diverse Latinos. It's not only talking about Puerto Ricans here or here in Chicago. We have 70% of our Latino community being represented by nuestra comunidad mexicana, and we have all other Latino America represented. So this cultural humility is connecting. I would have to echo José's comment. It's validating experiences and tradition and folklore and understanding how that comes into play when people are seeking medical care, how they envision their health to be. So when you validate patients and you take into account their opinions or their values, principles, and the way that they envision their care, you're really accepting and celebrating that uniqueness that comes where all Latinos, in terms of their background and those different cultural aspects and nuances also, we need to learn how to navigate and respect. So I think that all complements the trust, and it complements the care that you're giving to your patient, and it all is important when you're providing that care. So yes, it's so important in our communities.
Awesome. Thank you so much. And so we'll go into institutional barriers. Yeah. So we know that institutional barriers can greatly impact the experience of Latino medical students and physicians. What are some common challenges faced by Latino students during their medical education, and how can institutions better support them? And I think this is one aspect we wanted to talk about is, and I mentioned it a little bit before, but I do think there are these institutional barriers, as I mentioned, from undergraduate studies to MCAT. It's they do occur, and while the student is navigating their socioeconomic differences, but the goal, right, is excellence, right? We are all physicians. We have all jumped through the hoops of getting into medical school, residency, board certification. But how I think it's an important question is what are some of those institutional barriers that you see, and is there anything that we can see in our lifetime to make it better, right? So that there is some equity when these students are trying to get into medical. So as we try to increase and diversify our physician workforce, do you envision anything that could change? Dr. Mora?
One aspect that I wanted to talk about in this specific question, Michael, burnout. Just because our Latino students might have a bigger burden, as I think all of us did when we were doing our medical school rotations and our residency, because guess who was the Spanish speaking person on the team, right? Who is going to handle the most patients on the team, on the wards? Who is going to be the one to have to tell that family that their child has cancer, even though you're a medical student and you have no idea how you're going to comfort this family, but you have to break the news because you're the one that speaks Spanish. Yeah. So I honestly believe that we need to better support our medical students so that those resources are in place where they don't have to feel like they have to take care of everyone.
Yeah, yeah, that's a great point.
Yeah, and they have a chance to really learn and take the time for themselves.
And that's why this focus on valuing culture and language with this movement. I swear I'm not trying to plug NLPD the entire session, but like that has to be valued. And let me give you an example. At the LMSA conference, I'll keep her anonymous, but I met a Latina resident who's at a major pediatric hospital who started her residency. She was the only Latina of 38 or 40 residents. And that's insane. And their patient population is over 60% Latino. Can you imagine how she felt? She felt exactly as you said. She felt, incredibly burned out as she was hearing of things with some Latino and Spanish speaking families and knowing that these boxes weren't checked, right? Connections weren't made and having to take that additional work, resulting in burnout. And she was really brave and very assertive and called it out to her program. And there was some changes, it sounds like, and there was some increasing amount of Latino physicians that were subsequently enrolled. And it could have been a fluke, but it's definitely not a fluke when we see this disparity, and it really is affecting our patients. So yes. Dr. Luna, any other institutional barriers that we can see break down in our lifetime?
Because I think that's the way there are medical schools. I agree with you guys, not having a bicultural, bilingual school. Who teaches you? That's the biggest challenge. I think of a Latino student to go there to a medical school. Who teaches you how to take care of your own? So you're not getting that cultural aspect unless you have a program that supports an area, which should be automatically provided in, communities where the representation concentrations of Latinos are high. So I agree with Dr. José that here in UIC, which is the one that I attended as a faculty, we do give medical Spanish, but not when I started. We're talking about like 6 years ago. So individuals graduating before that, the ones that don't speak Spanish or culturally related, never learn those aspects. And those that are Latinos know how to treat a culture that is very different from their seniors that come to address them if they don't get that more that exposure that it's so important. So that cultural competency has to mirror the community that you're serving. I think that's one of the biggest challenges Latinos are represented when they're automatically accounted to care for their own. And nobody is teaching you. I didn't get that experience because I come from Puerto Rico. So everybody, we're culturally trained to address our communities. But here in the United States is a huge challenge, and it has to come to those conversations so we can change it, especially where communities of Latinos are highly concentrated and represented there.
Yeah, and increasing as we're seeing. Thank you so much. And Dr. Calderón, if you could comment on what institutional barriers you think could be broken down or that you've seen, and then we'll go into questions or Q&A.
Absolutely, Dr. Galvez. So I know I have already spoken about a couple, the mentorship part, the pathway part, the not understanding student needs, not understanding the difference in those student needs based on culture or based on background. All of those play a part, and we see them at all levels, more for students who identify with any ethnic minority background. We definitely see an overrepresentation of Latinos in that whole group as well. But one thing that historically I have been called a pessimist, and by, I don't know, my wife and my mom at some point. But there needs to also be a reframing of our thought process as to not only focus on, oh my God, this is a barrier, but how do we get around that barrier? How do we move forward? How do we look for alternatives? What do we speak about? Who do we speak about? Which definitely, for me, it took learning and practice. So one example that I'm going to use is very, very specific to our School of Medicine. So our current president is Latino. The School of Medicine is fully invested in trying to reflect a little bit more based on what our growing community needs are and who our medical students are, which again are increasingly Latino. Our community is 30% Latino. So the need is there. So the things that we can do, well, we definitely could speak about it during the pediatric clerkship. We could do continuous medical education, which I have done 2 this year myself as part of as part of faculty. Then on the other part was currently we have plans of expanding the Spanish for Medical Encounters rotation to actually become a scholarly concentration. So with the goal of providing our medical students here at UNR Med a more longitudinal experience. So that will lead to higher engagement with two big benefits. So number one is going to be, all right, you're going to get to meet your Spanish-speaking, likely Latino faculty earlier in your career rather than when you're doing clinical rotations, which is 3rd and 4th year. Okay, so that might end up leading to opportunities for mentorship and support earlier. Okay, by people with whom you can identify with. Second, we are planning on introducing a certificate for medical interpreting in the pathway that is going to, so the students come out of that at 2nd year after doing a medical interpreter course and getting a certification for it, okay? Then we are going to go through the cultural humility curricula, which is part of what we have as our designation for the elective, with the clinical portion of the elective at the end. But before you even apply to residency, you are going to have a medical interpreter certificate as well as an AHEC scholar certificate, which is who grant funds our whole endeavor. So being able to look for things that you can change, that you can create, that you can modify to be able to meet those community needs is one way that I have decided to approach it here, but I feel might be a good thing to mirror, because if we try to focus on the things that they don't let me do, or the fact that we don't have funding, then how can we work around that to still meet that community need? Yeah. Be flexible. Being flexible and looking for collaboration is really, really, really important. And for some people it might be a learned experience, but it definitely pays off.
I really like that. It shows, yes, someone brought up a question, what do we see in the future and projections in states like Texas that have eliminated funding for diversity, equity related programs and essentially banned it, right? Exactly as you said, you have to meet the patient population. How can you ignore the demographics, right? And so I agree that there are many ways to meet the patient population by focusing on these aspects like language and culture and teaching it in new ways and providing a pathway. And from what I understand too, there are only 2 medical schools in the United States that have some type of Spanish requirement, like a basic Spanish requirement. I need to look into what those details are, but I don't think it's as unique as having a certificate. And so anyway, so yeah, that thank you so much for your comments. And so there's a few questions. So how can we get more participation from medical schools on this issue? That's a great question. That's where I think the first thing is awareness, right? I think, yes, there are the academic portion is really important. The research part is really important. But the awareness on these issues becomes important. That's I'm not trying to plug National Latino Physician Day, but that is how we get people to say, hey, why is there even a National Latino Physician Day? Why do we even have to celebrate that? Then when you ask the question, then you need the answers, and the answers from a Latino doctor, just as yourselves, will educate, and then we will be at that table. We will be able to say, yeah, we have a growing Latino patient population. Yeah, I am the expert, and or I can help find the experts, and this is how we can potentially change. And so I think we did address some of those questions. And so another question someone had was, what are the opportunities that exist for mentorship? For example, I'm starting medical school this upcoming July. I'll comment on mentorship, and then maybe a few of you can comment as well. I know our time is running out, but for mentorship, mentorship starts with being assertive. So when you start medical school, you start looking around, you start making conversations and meeting people. And for me, it was always, I did a lot of shadowing as a pre-med and in medical school too. And that's how I figured out who I thought could be a potential mentor. You're going to have multiple mentors. It's not just one. You can have a research mentor. You can have one who's focused on your specialty. But I do think it's important to be assertive.
Michael, there is also a National Hispanic Medical Association has a mentorship program. So for the person who asked the question, they can sign up and they will get actually matched up with someone who will mentor them throughout their medical school career. They can stay throughout their residency as good friends and colleagues. So I think that's a wonderful program for people to get involved with.
Yeah, if you're in Chicago, I would highly recommend also the Medical Organization for Latino Advancement. And there's organizations like the one that we were talking about, Hispanic Serving Institution, that also has Hispanic Center of Excellency. That is a way that medical students can pair up and receive funds and different programs and access to mentorship. And,
Yes,
it's a very stricter program. So all of these are very helpful.
Fantastic. Well, thank you so much. I do have to close, unfortunately. Thank you to our guest speakers. Thank you so much for the questions. Appreciate everyone's expertise. This will be posted on YouTube within the week, and we hope that everyone enjoyed this informative conversation. Please join us at the 28th Annual NHMA Conference. It's going to be March 20th to March 22nd, 2025 in Anaheim, California. If you're interested in being part of the mission of NHMA, please consider becoming a member. There's this QR code right here. And of course, you can get connected to NHMA on social media. So thank you, everybody. And enjoyed having everyone here today. Thank you so much, NHMA, for this opportunity today. Have a great day, everybody.